Hi, good morning, friends. Since we are meeting for the first time in 2023, so Happy New Year to you all. We are here again with our new session, which is 7th in the series of 12 webinars, which are brought to you by GP Clinics through our own digital platform, dockieslive.com. As you all know, I'm Dr. Anupam Agarwal. We publish GP Clinics, which is a CME journal for family physicians, and it is being published every month for the last 12 years. Today's subject is Pallor, Bedside Diagnosis Possible. The recordings of all the previous sessions on fever, cough, diarrhea, constipation, vomiting, and abdominal pain, which have been covered so far, all 6 webinars, are there on our website, gpclinics.in. And a summary of each session with questions and answers is published in GP Clinics every month in the print medium. Another important observation, I inform you that we are getting a tremendous response to our book titled What Doctors Must Learn by Dr. Y.K. Amdekar. And for all of you to know that we are giving this book free with GP Clinics, and you may go to our website for details. The book costs about 900 rupees at Amazon, but we are giving it free. About the speaker, Dr. Y.K. Amdekar, as you all of you know, he is a practicing pediatrician for the last 50 years. He is currently a visiting consultant to SRCC Hospital, Mumbai. He has been a faculty to Grant Medical College, JJ Group of Hospitals, and Institute of Child Health, Mumbai. He has been the past president of IAP as well. So over to you, sir. Floor is yours.
Thank you very much, Anupam, and good morning, all my friends. I think today's topic is pallor, as was mentioned. And I want again to emphasize that the discussion does not really take care of only the pediatric part of the story, but also it is as much applicable to adults as well. And I think, therefore, I've chosen cases also which are of older children, which are almost like the same issue like what you might see in adults as well. Can I have the first slide, please? The next one, please. Now, as usual, we start with the basics. And I think basics is always so important for us to understand how we go about further discussing our clinical issues. Now, mostly pallor of the skin is anemia. Okay, which is because of the hemoglobin is reduced and you have a low hemoglobin. We understand that. But it is more important to know how does this hemoglobin come up at all. You know that there is a stem cell in the bone marrow which maturates and goes through various stages. And one of the stages is normoblast, at which time a hemoglobin is incorporated into the cell. So please take a note that a stage of RBC development before normoblast does not have hemoglobin. And what is important, if that stage also suffers because of hemolysis, then there will not be any jaundice at all. Because it's only the hemoglobin that breaks down and forms jaundice. So the normoblast is a stage where hemoglobin is incorporated. And more important is, these normoblasts are not seen in the peripheral smear normally. So if you see normoblasts in the peripheral smear, it means that the bone marrow is in a hurry to throw away the cells into the periphery. And that's what happens in a classical chronic hemolytic anemia. But the next stage of normoblast is the reticulocyte, which is seen in a peripheral smear, but extremely small number, because the lifespan of a reticulocyte is just 1 day. And every day there is a destruction and a reformation of reticulocytes. But the next phase is a mature red blood cells, which have a long life of 120 days. And subsequently, at the end of 120 days, those old RBCs are lysed, destroyed. Hemoglobin is coming out. The hemoglobin is heme plus globin, and heme has iron. So iron and globin are stored in the body. And the biliverdin, which is an indirect bilirubin, is further got into a liver and made to direct bilirubin and excreted in the urine and stool. That's how the normal RBC cycle continues to do that. Now you naturally need the nutrients to develop hemoglobin. And the most three common factors responsible for developing hemoglobin in terms of nutrition are iron, B12, and folate, but also vitamin C, thyroxine, and many other small factors contribute, but they are not major factors. What does it mean? That vitamin C deficiency or thyroxine deficiency, like a hypothyroidism, for example, the patient do have moderate or mild anemia, but not severe. So they don't present with anemia, but they also have a mild anemia. But if you are short of iron, B12, or folate, then the anemia could be even severe. And therefore, we generally attend to these three elements as cause of nutritional deficiency. Well, besides the deficiency anemia, there are hemolytic anemias, which means that the RBCs are hemolyzed too many or too fast. And there are also marrow disorders where the marrow does not work at all, like marrow aplasia, or the marrow is infiltrated by something, and that's why the marrow cannot work. So, friends, we have three types of anemia: deficiency anemia, hemolytic anemia, and a bone marrow disorder. Deficiency anemia, iron, B12, folate as most important. Hemolytic anemias, acute and chronic. And marrow disorders, either the marrow is suppressed, which means all cells coming from the marrow, RBCs, WBCs, platelets are all down, or the marrow is infiltrated by some unnatural substance, and because of that, the marrow doesn't work. You can imagine when the marrow is a factory. So if a factory which produces some items is not working, there could be two causes. One, either the factory is lockout. That means everything is standstill, everything is quiet. That's what bone marrow aplasia or aplastic anemia is. But on the other hand, the factory may be very active, but active with criminals or active with people who are not working but making noise. And that is what is bone marrow infiltration, like leukemia, for example, or many others. So when you look at anemia, you simply look at, you go to the market and ask for some item, and the shopkeeper says, oh, now this item is not available. You say, why is it not available? Oh, either the factories are not working, or the factories are working, but there is no availability of raw material, that is deficiency, or raw material is available, factory is producing the item. But when the item is transferred from factory to the market, it is somewhere lost. And that is hemolysis. So you can simply understand the story of anemia by, if you don't find some item in the market, you wonder whether factories are working. If factories are working, then why raw material is not available, or somewhere the traffic, a lorry traffic from factory to market is obstructed, and that's why the market does not have that item. That's why three types of anemia: deficiency anemia, hemolytic anemia, and a bone marrow anemia. Well, sometimes there could be an acute blood loss. For example, somebody has a large amount of hematemesis or a bleeding from some site, which also presents as severe anemia, but an acute anemia presents as shock, whereas a chronic anemia may present with a congestive cardiac failure. All such basics are extremely important because we will know how to apply it, and we will try it in subsequent cases. Now, let me give you, next slide, please. This is your interaction now. Pale skin may be a manifestation of anemia, shock, or severe edema, or all of the above. Your time starts now. Excellent. I think majority of you have said that anemia can present as, of course, pallor is due to anemia, yes, but also pallor is due to shock. Pallor is also due to severe edema. And the point I wanted to make is that when you see somebody pale, he may be in acute shock, or he may have a very severe edema like a nephrotic syndrome, where the whole skin is stretched by edema and the skin looks pale. Or, of course, the most common cause that there is anemia. So please take a note that if somebody says, "Oh, I'm looking pale," don't jump to just consider anemia, but something even other. The next slide, please. There is another interaction for you. Okay. Now look at this. It is ideal to assess anemia by examination. Please make a note. What would you examine to assess anemia? Conjunctiva, oral mucosa, palmar creases, or all above the above? Please make a note and a question. I am asking what is most ideal? Is it conjunctiva, oral mucosa, palmar creases, or all of the above? Your time starts now. Well, almost you are all there. You are right. When majority of you have said all of the above are right, yes. But what I wanted was what is ideal. Now take a note. If conjunctiva is looking pale, yes. But if there is a conjunctivitis or any other reason for conjunctiva to look a little more hyperemic, the pallor would be easily hidden. So a pallor may be missed even when conjunctiva may not look pale. Okay, take a note. Not certainly common. You are all right. You see it conjunctiva, you see it oral mucosa, palmar crease well. But conjunctiva could be misleading. Similarly, oral mucosa could be due to glossitis, stomatitis, which is not uncommon. And then you will miss pallor. But the most ideal place is palmar crease. And what is important of palmar crease? It also tells you the severity of anemia, degree of anemia. What does it mean? Normally, if you look at the creases, then the creases are usually visible under the background of a pinkness of the palm. But when the palm becomes pretty white, even the creases become white and the creases are not even seen. That's how palmar creases are an excellent way to judge anemia. Not only judge anemia, but even the degree of anemia, the severity of anemia. So if you don't see on some palm the creases at all, you will know that it's a very severe anemia, possibly maybe 5-6 grams of hemoglobin and not more. So this is just to make you understand how it's important to look at the palm more than, of course, conjunctiva oral mucosa, you're all fine. Let me have the next slide, please. Now, let me give you a simple clinical approach to anemia. Okay, age is important because many chronic hemolytic anemias often start in childhood, and most deficiency anemias are also seen in childhood, but not very early in infancy. The common age of iron deficiency anemia is about 6 months to 2 years. Of course, in India, almost all children and women are mildly at least anemic due to iron and B12 deficiency. But some diseases are more common at particular age. A malnourished child, of course, will have deficiency anemia, but remember, even the most healthy child also can have a deficiency anemia, because today's healthy child eats all abnormal nutritious food. He takes a lot of calories. He goes to malls, and we call it a malnutrition, not malnutrition. Malnutrition. What do you eat there? Pizzas, burgers, whatnot. And they are obese. They look healthy, but they are not taking enough iron, B12, etc. because of the junk food. Micronutrients are not going in, and therefore, healthy people also may be anemic, often deficiency. Sick or not sick is a very important question in anemia, because chronic anemias like chronic deficiency anemias or chronic hemolytic anemias are not sick. But when anemia occurs acutely, or if it's due to bone marrow disorders, most of these children are sick. Most of these adults are sick. Therefore, sick or not sick can make a difference in our assessment. Of course, I talked about how to judge severity of anemia, and the importance also whether the anemia is acute, short duration, or chronic. Acute anemia, short duration, are either acute hemolysis or acute bone marrow aplasia. And a chronic is, of course, chronic deficiency anemia or a congenital hemolytic anemia. Having said this, it gives you an idea where is your probable diagnosis of anemia, but make a quick note of this kind of a 5 things that I have put down on this slide. You always look at liver, spleen, whether child of Pallor also has jaundice, whether he looks sick, and what are any other signs. And if you look at these 5 things, you will diagnose the type of anemia. Look at that. Iron deficiency anemia does not have a liver spleen enlargement. Okay. Acute hemolytic anemia may not have a liver enlargement, but has a spleen. But the chronic hemolytic anemias and a bone marrow infiltrative disorders like leukemia have liver and spleen, but a bone marrow aplasia does not have liver and spleen. You got this? So when you got no liver and spleen, either you have a deficiency anemia or a bone marrow aplasia. And what's the difference between the two? The deficiency anemia are not sick, mostly, plus minus, but a bone marrow aplasia are sick. So sick child without liver and spleen enlargement, bone marrow aplasia, mostly, and a comfortable child with anemia but no liver and spleen is a deficiency anemia. Simple, right? What about acute hemolytic anemia? Yes, may look sick, but a chronic hemolytic anemias are not sick. But chronic hemolytic anemias have a lot of enlargement of liver and spleen, especially the spleen. Whereas a bone marrow infiltration like leukemia also have a liver and spleen enlargement, but chronic hemolytic anemias are not sick, and bone marrow infiltrative lesions are sick. So did you get the point? Simply sick or not sick, and whether liver and spleen are enlarged or not enlarged, can almost make a total differentiation between all this. I'm sure all this will be published in the next volume of GP Clinic, and you will have all this right with you. But this is just to explain how important it is to look at liver, spleen, and sickness. Well, jaundice is mostly seen only in hemolytic anemias, but occasionally may be seen in B12 deficiency as well. And then you look at some other specific factors like iron deficiency anemia have a platinikia or a koilonychia. The nails are spoon-shaped or flat. A B12 deficiencies have a pigmentation at the knuckles of the fingers. The chronic hemolytic anemias have a poor growth. The marrow aplasias have a purpura, and a leukemia may have purpura also, but also have a bony pain. So this is a simple clinical approach, and I feel that's why today's title is Anemia, a Clinical Diagnosis is Possible. You look at how simple it is. Now, why do you need investigation? To see what's the cause of hemolysis, what's the cause of deficiency, what's the cause of bone marrow aplasia or infiltration? Yes, you can not make out so much, but the groups are easy to make out. Can we have the next slide, please? Now, let's go to 8 cases as usual, and you will give a good thought to the details that I mentioned. Now, this was the 1-year-old child presented with pallor noticed over the last 3 months. No other complaints. Exclusively breastfed for 6 months, followed by little cow's milk and occasional rice. His weight is 8 kilos, a little less than average. He has a significant pallor. He has no hepatosplenomegaly or jaundice. Take a note. It's a chronic anemia, 3 months. Okay. He is not sick looking, but severely pale, and he has no hepatosplenomegaly. But his weight is a bit low. And look at his diet, mainly the breast milk and a little cow's milk, but hardly any other solid food. Now, your probable diagnosis is iron deficiency, B12 deficiency, or a marrow aplasia, or any of the above. Your time starts now. Excellent. You're bang on that. As I said, chronic anemia is without liver and spleen. So, bone marrow aplasia is an acute anemia. And the chronic anemias are chronic hemolytic anemias or a leukemia. But then there is also liver and spleen. So, this must be a deficiency anemia. Now, you're right. Some of you have said B12 also, but majority of you have said iron. Yes. I wanted you to give a good look at that. If the child is breastfed, even for a long time, breast milk is an excellent source normally for iron only up to about, say, few months. Thereafter, he has to depend on a lot of other sources, and cow's milk is a poor source, but he is not taking any solids at all. That's why, very likely, he has an iron deficiency anemia, and you will see that somebody said B12 because he must have noticed that the milk intake is very poor. Yes, you are right. Those who have a very poor dairy intake also tend to have B12 deficiency, but the breast milk given for first 6 months give a reasonably good amount, and thereafter he continues to breastfeed. So that's why likely most iron deficiency anemia. But good that most of you almost said, but few of you said marrow aplasia, but marrow aplasias are also without liver and spleen, but it is usually an acute disorder. Aplastic anemia is an acute disorder, and therefore this was chronic for 3 months. Therefore, it is not marrow aplasia, right? Good. Can I have the next slide, please? Now, here is your second case. Again, a 2-year-old, similar. Again, chronic, 3 months. Okay. Again, breastfed for 6 months, but followed by family food, but small amount of milk. Okay. He's taking mainly a family food now. At 2 years, he is not getting any breast milk, and he has hardly any extra source of dairy. But he's taking family food. Look at his weight, fine, 11 kilo is fine. So he has enough of calories and proteins, but even then he is pale. He has no hepatosplenomegaly or jaundice. But take a note, he was also noticed to be severely pale at 1 year of age. That means about a year of age. And he was given blood transfusion. We don't know the details, but he got well. And he remained well for another 12 months. And now he has come back with again severe anemia. Now your diagnosis again is Similar, is it iron deficiency, B12 deficiency, marrow aplasia, or none of the above? Your time starts now. Very good. I think you all have started thinking reasonably well, but let me again get you to a little thing. It's a chronic anemia, right? So, chronic anemia in a 2-year-old child, and he has grown well, so he's not sick. So, chronic anemias who are not sick are likely to be chronic deficiency or a chronic hemorrhagic. But he does not have any hepatosplenomegaly. Bone marrow disorders are usually sick children, whether bone marrow aplasia or a bone marrow infiltration. He has grown well. He has an anemia for 3 months duration. In spite of chronic anemia, he is not sick. And he has no hepatosplenomegaly. So he must have a likely to be a deficiency anemia. Now, what deficiency? Again, the similar thing. Good diet, but a poor in B12 content, especially if he's a vegetarian, then he doesn't get any much B12 source, and the only source would be a good dairy, and he's not having any dairy. But why did he have a transfusion a year back? I think that misled some of you, and many of you therefore said it cannot be any of the above. Yes, your thinking is absolutely right, but I put up such cases, as I've already said in this kind of webinar, that I strongly believe that those of you who are attending such webinars in all different subjects want to keep updated and want to keep learning more and more. And therefore, I put some tricky situations. This is not uncommon, that a vitamin B12 deficiency is often not diagnosed correctly and just given a transfusion because the child is very sick. But then why not a hemolytic anemia? You are right. Most of you have said because there has been a past story of blood transfusion, it must be a hemolytic anemia. Yes, you are right. But a hemolytic anemia would have had, a chronic hemolytic anemia would have had a liver and spleen. But you got misled with that blood transfusion. And my point is, it is not rare that a B12 deficiency is not diagnosed unless you do a serum B12. And serum B12 is also not a very good test for a B12 deficiency anemia. In fact, the homocysteine is a better test, but commonly B12 is done. And I'm sure you might have seen a low B12 without anemia. Okay. Or a severe B12 deficiency with a normal serum B12 levels. So that's why just because somebody got one transfusion in the past, you got misled and you said that, oh, it must be hemolysis. You are right in thinking, but I wanted you to take a little higher level. Chronic hemolytic anemias would have had a hepatosplenomegaly, and this child does not have. So this was just a B12 deficiency anemia, right? Let's have a next slide, please. Now, here is a 4-year-old child. Now, look at the child is a little older, and he presented with a pallor notice over last 4 months. Again, chronic, but no other symptoms. Now, look at physical examination very, very closely. He's not looking sick, but he has a poor height. He has abnormal facies. He is severely pale. He has a liver and spleen much more than liver, and he has no jaundice. And he also had a transfusion a year ago. Now, what is your probable diagnosis? A deficiency anemia, hemolytic anemia, marrow infiltration, or marrow aplasia? Your time starts now. Excellent. I almost thought that almost all of you would get the right answer, and it is a hemolytic anemia. It is a chronic hemolytic anemia. Now, I did mention initially in a clinical approach slide that hemolytic anemias often will come with jaundice as well. They not only have pallor, but also jaundice. But thalassemia major is one type of chronic hemolytic anemia where there is no jaundice. And this is because what I talked to you in the very first slide of the basics, that the destruction of RBCs take place very early in the stage of development. That means even before the normoblasts arrive and the hemoglobin is put in the RBC, a stage prior to that only the RBCs get destroyed. And when RBCs are destroyed so early in the stage of development, you don't have hemoglobin in that, and therefore there is no heme or globin breakdown, and therefore there is no jaundice at all. Okay, and therefore this is typically a thalassemia major. A point I want to stress is majority of hemolytic anemias have also mild jaundice, and if this child had no jaundice, then this was typically a thalassemia major. And marrow infiltration, yes, because of liver and spleen, but children with marrow infiltration are going to be sick children, whereas a marrow aplasia is an acute illness, and deficiency anemias do not have liver and spleen. Therefore, diagnosis was the hemolytic anemia, right? Good. Let's have a next slide, please. Now, this is your 15-year-old now, who is presented with gradually increasing headache. Take a note of this story. This is just to tell you how sometimes a pallor may not be a presenting feature, but something else present, and you find on examination you have a pallor. Okay, so this was 15-year-old presented with gradually increasing headache and pallor, notice over the last 4 weeks, and developed a focal seizure involving left upper limb. You can imagine, so far all 3 cases of pallor did not have any headache or any neurological symptom. Okay, take a note of this. But pallor, all right. What do you find on physical examination? A mild weakness of left upper limb, but no hepatosplenomegaly, no purpura. He is not looking sick. He is otherwise okay. Okay, but there was a past history that when he was playing football a month ago, he had a severe injury. He fell down on his head. And that was the only time past history. And over that period of time, within a day or two, he started developing headache, also started developing pallor, and just before coming to the hospital, he also developed a focal seizure. Take a note of all this. Not so chronic. History of injury, headache, pallor, and a focal neurological symptom and sign. Your choices are deficiency anemia, marrow aplasia, hemolytic anemia, or a marrow infiltration. There is a small trick in this. Please take a note of this. Which of these 4? I have not said none of the above or any of the above. So it has to be one of these 4. Okay? Your time starts now. Well, nobody said marrow aplasia. Yes, because now take a note. Headache. If there is a chance, we can do some such webinar on headache also. But what does headache really indicate? Headache starting after a severe injury whereas there is nothing seen from outside. So headache suggests an increased intracranial tension. So there is something happening in the bone, in the brain, inside the skull. That's why headache. Okay, and it started after injury. So this must be a traumatic brain problem with an increased intracranial tension. Why does an increased intracranial tension occur? Because there is something occupying extra in the skull, in the brain. Now, what can occupy in the brain after a trauma? So there must be a bleeding occurring. Okay, that much we came to know. A bleeding occurring, but a bleeding occurring slowly over a month, causing headache and increasing pallor. As the bleeding starts occurring more and more, the blood is getting lost. But this is not a sudden large amount of blood loss. This is a small amount of oozing. And therefore, this presents as a deficiency anemia because of a chronic slow oozing of blood. Okay, after all, when you have a hookworm deficiency or a hookworm infestation, the hookworms eat up all those iron, and ultimately you have a chronic iron deficiency anemia. Or if you have a small bleeder like a polyp in the intestine and it bleeds off and on, a chronic bleeding causes a deficiency anemia. Acute bleeding of a large amount causes shock. So this child has a chronic, slowly occurring over a month, a small amount of oozing of blood after an injury. And then when it became large enough, it threw up a localized seizure. That means it was the localized hematoma, and the diagnosis was a deficiency anemia caused by a subdural hematoma. That's why a neurological symptom along with anemia. Okay, certainly not common, but I'm sure very old age, you do get such trivial head injuries and a subdural hematoma. Why does subdural hematoma occur over weeks? But a subarachnoid hemorrhage occurs very quickly. The reason is in subdural space, there are veins, not arteries. And therefore, the venous trauma has a slow oozing, whereas an arterial trauma can be massive. Unless you have a dilated veins, you don't get a massive blood loss, sudden blood loss. But you know that in a varicose vein, when the veins are dilated, you get a massive hematemesis. But in a subdural space, there are small bone veins, and there is a slow oozing. That's why this was a subdural hematoma with iron deficiency anemia, right? Next one, please. Next slide, please. Now, this was another 15-year-old who presented with an increasing pallor over the last 1 month. Again, make a note, this was not very acute nor chronic. Let's call it a subacute. The last case was also subacute. And this child was noticed to have a facial deviation noticed over last 1 day. The last child came with an upper limb paralysis. This child has come with a facial palsy. Notice only 1 day, but an anemia is gradually increasing over the last 1 month. Take a note, subacute anemia, not very chronic, increasing, worsening, ending with a facial paralysis. Patient is not sick, there is no jaundice, there is a liver enlargement, there is a spleen enlargement, and of course a left facial palsy. Your probable diagnosis is deficiency anemia, hemolytic anemia, marrow aplasia, or a marrow infiltration. Your time starts now. Uh, Friends, these last two cases, this one and the previous one, I've included only to take you to even a higher level of thinking. Okay, I did not expect most of you giving a right answer. Yes, but I wanted to stimulate your thought process. Take a note, this is a subacute one. Okay, so, and with hepatosplenomegaly. Now, those with hepatosplenomegaly are either bone marrow infiltration or a hemolytic anemia. Okay, that much we knew. But hemolytic anemia is chronic or a long-standing chronic disorder, not weeks or months, even longer. Whereas this is a subacute. So this is unlikely hemolytic, even when there is a large liver and spleen. But could it be a bone marrow infiltration? Yes. But again, I wanted to bring out this factor to you that not all bone marrow infiltration are sick children. The bone marrow infiltration caused by leukemia or a cancer are sick children, but bone marrow infiltration caused by non-inflammatory disorders are not sick. And there are several examples of this. For example, there could be an abnormal storage. Some abnormal material gets stored in the skull bones or bones everywhere. And this child also has a left facial palsy. This is a rare condition. I just wanted to bring this forth because not all bone marrow infiltrative disorders are sick. This is a condition called osteopetrosis, where the bone marrow bones get very thick. And when the skull bones get thick, anything that is leaving the skull gets pinched. And a facial nerve, which leaves the skull at the stylomastoid foramen, gets pinched. And when it gets pinched, you get a facial paralysis. And that, together with severe anemia, becomes a bone marrow infiltrative but non-inflammatory disorder. And this was just to bring out another unusual case. But again, let me point out, these are certainly rare, but I'm sure I anticipate all of you to be now at a higher level of thinking. And that's why I keep on reading even at the end of 55, 60 years of medicine, because I feel that more you read, more you look, more you know. I think you know that how less you know. And this was just to bring out that kind of a stimulus in that. Forget about osteopetrosis, but give a thought process how you arrive at a marrow infiltration. And I'm not surprised that 1/3 of you did pick up a marrow infiltration. Good. Let me have the next slide, please. Now, this was 17-year-old. I'm taking out the older ones now, who start with fever and joint pains involving both knees and ankles over the last 4 days. Acute onset. Yes, fever and joint pains. Diagnosed as evolving arthritis, treated with steroids and NSAIDs, and look better. Okay. But recurred after stopping these drugs. This is the time that the patient presented to you. He's looking pale, he's looking sick. He has a liver, he has a spleen. Now, what is your probable diagnosis? Is it deficiency anemia, hemolytic anemia, marrow infiltration, or marrow aplasia? Your time starts now. Yes. Majority favor marrow infiltration. Very good. See, you have a liver and spleen, so you have a hemolytic anemia, chronic, or a marrow infiltration. Marrow infiltration in the sick child. Okay, previous one, marrow infiltration was not in a sick child. So what happens when there is a marrow infiltration in a sick child? It's an inflammatory disorder, and this is how the leukemia presents. The point of interest in this child was many leukemic presentation is a bony pain, and this child complained of pain in the knees or ankles, and somebody said you have an arthritis. Make a note. Only pain without swelling may not be arthritis, and it is not rare to miss leukemia as a rheumatological disorder. This was typically a leukemia with liver and spleen bone marrow infiltration. And why did he improve? He was given steroids, and for a short time he looked better, and he came back with vengeance. This was typically a leukemia, and the point was it may fool you and me as a rheumatological disorder, right? Good. Let's have a next slide, please. Now, this was an 8-year-old child who presented with pallor noticed over the last 6 months. Again, make a note, a chronic but presenting little late in the childhood. Okay. Past history of general weakness, recurrent swelling of the face or feet, and a poor growth. So here is a child who is sick, but chronically sick. His pallor is noticed only last 6 months, but much before that, he used to have swelling of the face, feet. He's not growing well. He's feeling tired. What does it mean? He has a chronic, slowly progressive illness, but that has ended up with pallor now only for last 6 months. When you examined him, he had a hypertension, 160 by 100. Now your choice is it deficiency anemia, hemolytic anemia, marrow aplasia, or a marrow infiltration? Take a note. I have not said none of the above or above, all of the above. It must be one of these 4. Your time starts now. Excellent. I think majority of you are favoring a marrow aplasia. Okay. The point is, again here, the last case was looking like a rheumatological presentation, but it was typically hematological problem, leukemia. The previous 2 had a neurological problem, but also the hematological problem. And why we call them hematological? Because they present with pallor. Anybody who presents with pallor is hematological, but hematological could be due to some neurological problem presenting. And this was a marrow aplasia because of a chronic renal failure. Please make a note that a children with chronic renal failure also present with severe anemia. And this child had puffiness of face, edema, peat, poor growth, and hypertension. One common cause of hypertension in a young age, including children, but even in the middle age, is not a hypertension of idiopathic nature, but it's a renal disorder. Hypertension could be caused by chronic renal disease or acute renal disease. Hypertension can be caused by adrenal disease, pheochromocytoma. So, and hypertension could be a cardiovascular disease like a coarctation of aorta. So, this child had a chronic renal disease, one important cause of severe anemia in a middle age who have a chronic urinary problems, a chronic renal problem, and the reason is kidneys produce erythropoietin, which stimulates the bone marrow. When the kidneys are damaged, there is no stimulus to bone marrow, and chronic renal functions, dysfunctions present with severe anemia. All right. So this was a bone marrow aplasia due to a chronic renal disease. Let's have the last slide, please, on the cases. The last case for you. Next slide. Now, this is another older child, 15-year-old, with acute onset of fever, pallor, and jaundice for the last 2 days. Make a note, acute anemia, but with pallor and jaundice and fever, just 2 days. On examination, moderate pallor, not severe, but mild jaundice and only splenomegaly. What is your probable diagnosis? Deficiency anemia, hemolytic anemia, marrow infiltration, or marrow aplasia. Your time starts now. Excellent. I think this is the typical acute hemolytic anemia. It's acute. There is jaundice, there is just a spleen, and started with fever, short duration. Excellent. I think you all got the gist of different kinds of anemia, and I wanted to bring some complicated anemias so that you don't every time just give iron and leave them. You give a thought to it. Can I have the next slide, please? Now, here is your interaction in terms of investigation. Basic investigations to evaluate anemia must include CBC, RBC indices, which means MCV, RDW, MCHC, etc., peripheral smear, or all of the above. Your time starts now. Excellent. Wow, wonderful. Oh, wonderful. Okay. Every part of this is so important. And now, can I have the next slide, please? This tells you how important is MCV and RDW. Only focus on those two. I've also included MCHC and MCH. But even if you focus only on two, MCV and RDW, you will find that iron deficiency and thalassemia major and all hemolytic anemia. Look at the last point. Spherocytosis, sickle cell, acute hemolytic anemia. So, iron deficiency and hemolytic anemias have a low MCV and a high RDW. Right? So take a note of that. And now it's simple. Iron deficiency has no liver and spleen, and hemolytic anemias have liver and spleen. So low MCV, high RDW, that is red cell diameter weight. All these CBCs give you all this, but we don't tend to look at that. Now, what about B12? B12 deficiencies, okay, has a high MCV and a high RDW. Look at this now. Low MCV, iron deficiency, high MCV, B12 deficiency. Both have high RDW. Okay. What about low MCV and normal RDW? That is typically a chronic infection or a thalassemia trait, which means thalassemia minor. And how does a marrow disease look like? High MCV and normal RDW. Look at this. Simple, high RDW, iron B12 or hemolysis, of which iron deficiency and hemolysis, low MCV, B12, high MCV, fine. I think rest of the things are also giving additional information, but not so important. And I think we must master the minimum things that are maximally useful in our day-to-day practice. And I feel from today onwards, you will always look at MCV and RDW in your CBC report, which we tend to neglect, and we only see what hemoglobin is or whatever, right? The next slide, please. Now, again, your interaction. This is on management. This is a 2-year-old child who presented with severe pallor, no other symptom. His hemoglobin was 5 gram %, very severe. Okay. But he had no other symptoms, which means he was comfortable. And he has confirmed iron deficiency anemia. Now, how do you manage this child? Your options are you give packed cell transfusion, or you give whole blood transfusion, or you give oral iron, or you give intravenous iron. Your time starts now. Fine, we are all a bit divided, and half of you feel that you must give a transfusion. But remember, transfusion is not decided by severity of anemia, but by functional disturbance. This child is comfortable. Chronic severe anemias, patients are reasonably comfortable, and if so, there is no danger of cardiac failure. You stay back without transfusion. Friends, transfusion is very risky. Well, you will do NABO, RH, incompatibility, etc. Take care of all that. But there are many minor blood groups. And beyond that, many infections are transmitted through blood. Well, most of the laboratories check for HIV, check for hepatitis B, but you cannot test for hepatitis C. You are not sure about testing for malaria, any viral infection, CMV. Okay, many. And blood transfusion has a high risk of transmitting infections as well as transmitting antigen antibody complex reactions. And don't take blood transfusion easily. Blood transfusion has to be given only if there is no other alternative. So this child has no need for axial transfusion or a blood transfusion. What about IV iron? Yes, you might argue in favor of IV iron today because today you get an intravenous iron preparation without a risk of a side effects. Whereas when I was being trained, and only about 10-15 years back also, the iron molecule which was available for IV used to give a lot of reactions and sometimes even a fatal reactions. But today you have a better compound and a safer compound. But what's the idea of giving IV iron? It does not take care of anemia quickly. It only stores iron in your body and utilization is slow only. So take a note. IV iron does not improve anemia fast. It improves anemia slowly only. And therefore today, the message is all iron deficiency anemia patients who are otherwise stable, comfortable, you start oral iron, and in 1 week's time, with normal good amount of iron taken, you expect 1 gram of hemoglobin rise. If he was all right at 5 grams, he would be all right at 6 grams also. So can I have the next slide, please? And therefore, management decompensated anemia. That means either acute or chronic, but the cardiac functions are not normal or patient is in shock, of course, transfusion, but iron deficiency almost always is well treated with oral iron. Well, you have different types of iron. The most important and least best absorbed iron is the ferrous sulfate, which has only 20% elemental iron. A gluconate has a less side effects, but has only 12% elemental iron. And fumarate has a high elemental iron, 33%, but often has also side effects. So you have to choose what suits your patient between ferrous sulfate, gluconate, or maybe a fumarate. B12 deficiency is, of course, treated by a B12 For treatment, if the anemia is severe, you better treat with an intramuscular B12. You also get a nasal B12 today. It's absorbed through the nasal mucosa. And then, of course, give oral for maintenance. And same thing about folate, oral supplementation. The duration of therapy is important. For deficiency anemia, you not only want to correct anemia, but also give enough for storage. And don't forget, find the cause. The common cause of iron deficiency in the middle age or in older children is not nutritional, but slow losing of blood through the intestinal tract. Like, as I said, a bleeding problem in the intestine, like polyps, or in an old age, maybe a bleeding ulcer or malignancy and whatnot, right? Specialized management is, of course, not our part. The last slide, please. The next slide, please. I'll just end up by saying, when pallor is the chief complaint, it's always a hematological problem, but it may be primary hematological or secondary. We did see a chronic renal disease, secondary problem. We did see neurological disorders with secondary anemia. So please take a note of that. Clinical diagnosis is possible the way we discussed. Deficiency anemia is preventable. And today, large population in India are iron deficient. And my message is, if your patients have to be given some tonics, add iron to that. And you will have done wonderful. Don't forget that iron can cause a lot of subtle problems. And one of the big problems in children is the lack of concentration. And a child may not do well in school. Imagine such a simple cause of prevention, and a child is faltering in the school performance. Okay, of course, spatial management is all not our problem. And I hope today's session probably enlightened you on some aspects. Dr. Anupam, back to you. I have finished my presentation.
Okay, thank you, sir. It is almost 1 hour we have into this conversation. So with your permission, I can take few questions.
Sure.
So one of the participants asked how to judge serious anemia.
Well, I think serious anemia is judged not only by severity, but how ill the child looks. For example, acute leukemia is not very pale. The pallor is mild or moderate, but the child is very sick. So sickness, a sick child is a serious child. Okay, he may be chronically sick, like a chronic renal disease we talked of, or he may be acutely sick, like we talked of leukemia, but sickness, acute sickness or chronic sickness. What is chronic sickness? He's losing weight, he's tired, he's very sluggish, his appetite is gone, he's losing weight. That's chronic sickness. And what is acute sickness? Oh, he just looks very sick and he just lies down. So sickness is the way to differentiate serious anemia, and don't wait. Start investigating.
Another question is how to differentiate between acute and chronic anemia.
I told you that an acute anemia presents with shock if it is severe. And if it is mild, then an acute anemia is an acute hemolytic anemia or an acute bone marrow anemia. So every acute anemia has to be a bone marrow anemia or an acute hemolysis, but deficiency is almost never acute. Bone marrow aplasia is acute, but bone marrow infiltration may be acute, like leukemia, or may be chronic, like we saw a child with osteopetrosis or a storage disorder. So the main difference between acute and chronic is acute presence acutely, chronic presence over time, and acute severe will present with shock, whereas a chronic severe will present with a congestive cardiac failure, right? Yeah.
Another important question is which anemia should always be investigated?
Pardon, come back again.
Which anemia should always be investigated?
Yes, I think anemia in a low risk situation, you may not investigate, but at least do CBC. And I told you how to differentiate the type of anemia with CBC. But when I see an older child, or you see an adult, or you see an old person, and don't take it only as a deficiency anemia, investigate. But I would say that every significant anemia should have a CBC. And we saw how a CBC with MCV and RDW can make a group diagnosis very simple. But my point is that if I have a 1-year-old child who is only on milk diet, he is otherwise happy, CBC is enough. But if I have a 10-year-old child who is eating well and suddenly last few weeks or few days becomes pale, oh, I must investigate. But don't forget, first and the best investigation is a CBC, but complete blood count. Remember, CBC, C stands for complete. And what is complete? It tells you what the hemoglobin is. It tells you RBC count. It tells you RBC indices. MCV, RDW, the most important, but also MCH and MCHC. It tells you WBCs. If WBCs and platelets are all low, along with hemoglobin and RBC low, you know it's a bone marrow aplasia. If WBCs are very high, 1 lakh, and all lymphocytes, you know it's an acute leukemia. So CBC look at also WBCs and also look at platelets. If the platelets are low, you have possibly a bone marrow aplasia or a bone marrow infiltrative disorder. So take a note of complete blood count. And I'm sure all of you must have seen now today with automated counters, a big list of all numbers come in. But we tend to get confused with all those numbers. I would say that look at for pallor, hemoglobin, RBC, that tells you degree of pallor. MCV, RDW, that tells you type of anemia, and look at WBC or platelet, low or high. Low WBC, low platelet with anemia, bone marrow aplasia. And high WBC and low platelets with anemia, leukemia. Fine. I'm giving you a very simple approach. Well, I will only end up by saying this works 99%. But the super specialist will tell you, oh, it is not right always. We want to be right 95%. And if we are doubtful, we send it to a specialist, right? Good. I think we have had enough, Anupam. If there is no other question, I will write some more answers for your publication.
Okay. There are many questions trickling in. I think we can cover all these with your permission in the next issue of GP Clinics, right? So we are coming close to the session of today. Thank you, Dr. Sir, Amdekar Sir, for this wonderful session. We hope this interactive session would have been made learning interesting for attending doctors to help empower their practice. On behalf of GP Clinics and DocIsLive.com, I thank all the doctors who have attended this session. Please note the date for the next webinar. It will be on 26th of February, Sunday, 11 a.m. same time. The topic would be jaundice. Every yellow is not jaundice. So thank you once again to all of you. Good day.
Thank you. Thank you, my friend.